Director of Public Policy for the National Hemophilia Foundation, and welcome to our second webinar. The webinar, I want to make sure we thank our sponsors for this series. Our program sponsors, our lead sponsors, are CSL Behring and Pfizer, supporting the this is a series of webinars. We look forward the questions, those the webinar, and we'll add evening. She can use a
access care for you and your family, to help advocates understand what the ACA will mean for your health care in your state, because this is a state-based reform effort, and to arm you with the tools you need to make sure that the implementation in your state meets the needs of patients, that your voice is part of the discussion. So for this particular webinar this evening, we're going to provide an overview of state health insurance exchanges. We're going to discuss the requirements and options for states under federal law and rules. So the Affordable Care Act laid out some specific functions and requirements for the exchanges, and rules issued by the Health and Human Services and other agencies have clarified some of those rules in greater detail, and states must follow these in setting up their own exchanges. We'll make sure you understand what those are. We'll provide an overview of state action to date. There has been plenty of action already and more to come. And then review the options for advocates to engage in your state, so how you use all this information you get tonight to jump into the debate in your state. So I just wanted to step back a minute before we jump into the exchanges to really review three key parts of the Affordable Care Act. Obviously, there are many pieces. There's Medicare and Medicaid changes and other pieces, but I wanted to make sure we focused on three key pieces tonight. One is to improve the quality of health care, and this is to change the way health care is delivered, and specifically to make sure that we're developing a health care system that rewards value instead of volume. So your providers aren't rewarded just by ordering up more tests, but actually taking better care of their patients. To make health coverage work better for those who have it. And I will say that we know that more than half of personal bankruptcy filings are as a result of medical expenses, and the majority of those people had health insurance. So obviously having health insurance doesn't necessarily give you the financial security to get the care you need without losing your shirt. So the Affordable Care Act puts in place new And then the second key piece is this development of new marketplaces, these exchanges, for individuals in small businesses. And I'll talk now a little bit about why we need exchanges and why these two groups in particular, individuals and small businesses, will benefit from exchanges. Under a current system, most people get coverage through a large employer, and it works relatively well for those folks. In fact, I just want to share some numbers for you. 99% of all firms with 200 or more employees offer health coverage. So if you are fortunate enough to work for a large employer, you likely have health insurance. That number drops dramatically when you look at smaller firms. Under 200 employees, only 60% of companies offer coverage. And among the smallest companies, with under 10 employees, less than half offer coverage. So really, if you work for a large employer, you're likely to have it. If you don't, and you work for a smaller employer, you likely don't have it. So we see that certain segments in our employer-based system don't do well. Individuals, especially low-wage workers, and small businesses have trouble getting coverage. Either it's not offered to them or they're priced out of the market. One more number I wanted to share with you all. If it is a company that has many low-wage workers, only a quarter of the companies offer coverage. If they have fewer low-wage workers, 2/3 of the companies offer coverage. So again, we're really talking about low-wage workers and individuals and small businesses generally that have problems getting coverage in our current system. Exchanges, together with the insurance reforms that we'll touch on briefly, are intended to provide a better way for individuals and small businesses to get coverage. One example I want to share with everyone is that prior efforts by Congress to help subsidize the purchase of health insurance, this was done for laid-off workers under the, with the recession, and others who have lost their jobs and so lost their health insurance. Congress regularly came up against this challenge of we can provide a tax credit, but people don't have a place to go to get their coverage. Exchanges solve that problem. It's a place for individuals and small businesses to get coverage with a subsidy. Next. That last one. Sorry. Can you go to the one before? And the health insurance reforms, exactly. Most people, no, the next one,
yeah,
sorry.
I was going to say.
There you go. Okay, thank you. There are a number of insurance market reforms under the Affordable Care Act, and I want you to walk away from this understanding that they all apply to the exchanges. There was a set of early reforms that took effect soon after the law was signed in 2010, and you may have heard about some of these. Coverage for dependents up to age 26. No lifetime limits on benefits, so that if you're a person who needs expensive care, your benefits are not going to run out because you hit a lifetime max on how much the plan will pay. No pre-existing condition exclusions for children, and no rescissions. This is the situation where an insurer, you may make a claim for a costly health care episode, and the insurer goes back and looks through your application and will find any mistake they can to say you misrepresented your application and cancel your policy right when you need it most. And there were some high-profile examples of this going on. That is now prohibited from since 2010. And then there are a whole other set of reforms that go into effect in 2014. There can be no annual limits on your health benefits, in addition to the prohibition on lifetime limits that's already in effect. There can be no pre-existing condition exclusions for everyone else now, not just kids. So no one can be subjected to an exclusion for the health care they need. And there were many examples of someone who had a respiratory problem. The policy would offer them coverage for everything but their respiratory system. There are new limits on how much insurers can charge people based on various factors. They can no longer, in 2014, charge you more if you're a woman than if you were a man, or charge you more because of your health status than they would a younger person, a healthier person. So in the statute or the law, there are limits on the age ratings to say that the oldest person can be charged no more than 3 times what the youngest person is charged. And they allow for rating based on tobacco use. If you're a smoker, you can be charged 1.5 times as much as a person who's not a smoker. This may sound like it still allows for a lot of variation in rates based on various factors, and it is, but I will say that we know that in some states, the insurers could stack up a number of different factors that they So there could be differences by as much as 26 to 1 if you had the wrong factors. But really, want you to understand that these exchanges are just a market within a market. They're not a whole little separate silo where different rules apply. They are just this organized market within the broader state market. Okay, next.
And JoAnn, we did have someone ask if you could
Okay.
slow down just a little bit.
Am I speaking? You and my mother. I'm sorry. I will try. She's always said I talk too fast. I will try. That's a fair request. So what will exchanges do for individuals? One of the two groups that can go to the exchange for health insurance. The exchanges will allow for one-stop shopping, a gateway to coverage for 30 million people. So by 2019, 5 years after exchanges will have been up and running, 30 million people will have coverage through the exchanges under some of the official projections, although we shall see what it actually turns out to be. And the idea here is one-stop shopping. You decide you need health insurance. You go to the exchange, and you have a number of options available to you, an easy way to compare plans, and you can enroll right there through the exchange. This apples-to-apples comparison will be new for many people. Right now, if you look at some of your health insurance options, the options may be bewildering, and it's hard to decide how they differ and which plan is best for you. There are going to be clear choices now among 4 standard levels of benefits that we'll talk about more later, and make your shopping easier. One example where this has happened already is Massachusetts, you may have heard, has an exchange they call the Connector, and they have standardized levels of benefits so that instead of 60 different types of plans, there are 3 general types of plans, and it made it easier for people to understand the differences and make smarter choices for their own healthcare needs. And finally, the exchanges will be the only place where individuals can get these new federal subsidies to help offset their costs for their premiums and their out-of-pocket costs. Anyone who falls below 400% of the poverty level will qualify for financial assistance in the exchange. And I have here what that looks like. 400% of poverty for an individual is $45,000. And for a family of 4, it's $92,000. So it's fairly generous. By comparison, the Massachusetts exchange only went to 300% of poverty. So this is more generous than anything else out there right now. And the premiums are capped at a share of income, so that for a person an individual at $45,000 income will pay no more than $4,275 for their premium because it's set as a share of their income. I will say that for more information on this particular piece, one of your handout pieces does go through the subsidies in greater detail, so you can see there are actually 2 different ways that subsidies are provided. As I said, one is to limit the premiums that people have to pay based on their income, and for the lowest income at 133% of poverty, the help is greatest, so their premiums are capped at 2% of their income, and then it climbs up to this highest income level, pays 9.5% of their income for health insurance, and then there's also some subsidies to offset out-of-pocket costs, the deductible, the copays, etc. So I would recommend you look to that piece for more detail. Exchanges will offer help for small businesses that they don't now have. One thing it will do is give small business owners more choices of plans. They may now go with their particular workforce, 10 employees, 2 of whom have diabetes, 1 has cancer, a couple costly conditions, and go to an insurer to see what they can get. They're going to have many more options available through the exchange because it is this organized marketplace. It will also give their workers more choices. Most large firms right now offer, the largest companies with 5,000 or more workers offer, about half of them offer 2 or more plan types to their workers. But when you get to a small firm, 85% of those companies offer only one plan type. So if you're lucky enough to be working for a small business that offers coverage, that coverage option is 1. You take that plan or you get nothing. And so the exchange will offer those workers many more choices of plans than they would get right now, and frankly, many more choices than many workers in small and large companies get. It will also allow employers to pick the amount they pay towards the coverage and then let their workers choose their plan. You might have heard sometimes this is called defined contribution coverage. So the employer will say, for example, I choose to spend no more than $200 per employee per month on health care. Here is here's your check from me. Go shopping in the exchange and pick out the plan that you want. There may be a plan that costs $205 and the worker doesn't have to pay much out of pocket. If they want to buy up to more generous coverage, they'll have to pay the difference. Employers tend to like this because it gives them some certainty of cost, that they can pick the amount and let it grow at the rate that they want to let it grow, so they're not worrying about how much the premiums go up year to year. But it does put more risk on the worker, that if you're a worker or an employee who needs more coverage, or has greater health care needs, you are likely to pay more in the difference than a younger or healthier coworker. And finally, there's a federal tax credit for small, low-wage firms, and it's defined as fewer than 25 workers and the average wage of less than $50,000. That's currently in effect right now for small businesses, but beginning in 2014, when exchanges are in every state, this tax credit will only be available in the exchanges for small businesses with low-wage workers. Okay, next. The Affordable Care Act set up a number of different funding options for states to take on the planning and implementation of their state health insurance exchanges. And this is actually, for the budget wonks in the Affordable Care Act, this was designated as such sums as are necessary. So there's no defined bank on this funding for states. If they can establish a need for funding, they can get whatever they say they need to do their planning and implementation. One set of grants was called the Early Innovator Grants, and it's really focusing on the IT technology and development that states will need to use to put all this together in their exchanges, the enrollment and subsidy determinations and everything. There are going to be new IT needs in every state. There were big grants provided to 6 states and 1 multi-state consortium to put together some planning in this particular area of the exchanges and then let other states learn from those best practices or their work. There's also a set of funding called planning grants that went to all but 4 states, and I have them listed here. And then a final bucket is called establishment grants. There is an initial funding that 34 states have received, and it's 1 year's worth of funding with the option for a second year of this first level of funding if you need to do further work to meet the criteria for Level 2 grants. Level 2 grants is sort of the next step up when a state has met specific criteria to show progress towards establishing an exchange. They have to have established a governance structure, to have a budget and initial plan for financial sustainability by 2015. So the federal money to fund exchanges runs out in that year, and they have to have a plan for how they're going to go it alone after that, a plan to prevent waste, fraud, and abuse, and a plan for consumer assistance. And they have to do something specific to demonstrate that, either legislation or some other official state act to show that they're making progress and committing to trying to work on an exchange, and then will qualify for the Level 2 funding. Only Rhode Island has received this Level 2 funding under the establishment grants. So there are now federal rules that we have. There was a proposed rule that was released last summer that many people offered comments on. All stakeholders offered comments on the different open questions that the federal government put on the table in considering how to write the rules for the health insurance exchanges. It was made final just last month and will go into effect at the end of this month. And overall, it gives states considerable flexibility around key design choices. They really do set some minimum standards, but then largely leave it to the states to go beyond those minimum standards or to make some key decisions in designing an exchange that meets their state's residents' needs. And it outlines where states can use that discretion or rely on existing state insurance rules and practices. So some of this will build on what states currently do, and in other cases it's all new functions and filling some gaps. So they try to allow as much as possible states to build on what they currently do in putting together their exchanges. Now to go through some of what those minimum standards are that all exchanges have to meet. They must allow for easy plan comparison. These are those 4 coverage tiers based on patient out-of-pocket costs that I referenced earlier. Just want to linger on this a little bit. And you do have a fact sheet on this. It's called the Standardized Health Plans 4 Tiers of Coverage. But this is the piece of the law that makes plans slot their benefits into one of 4 buckets so that you as a consumer can compare plans more easily. And the difference in the coverage tiers is based on how much a patient can expect to pay out of pocket versus what their plan will cover. And this is for an average patient population. They look at all the population of patients and come up with some average patient and run them sort of through a plan design and say, for that plan, the patient can expect to pay 40% of all the costs incurred during the year, and the plan will pay 60%. That is the lowest tier of the 4. It's called the bronze plan. It goes to silver, which covers 70% of the costs are covered by the plan. A gold covers 80%, and platinum, the most generous plan, will cover 90% of an average patient's healthcare expenses. A couple important points. Any particular patient may actually have very different healthcare expenses depending on their particular needs. This is about an average patient population. And this is not the same thing as the premium. The premium, 2 plans can have the same actuarial value. They can both, on average, pay out 60% of healthcare costs for an average patient. But the particular cost or the premium may vary based on the utilization of the people enrolled in the plan, the actual prices they negotiate, the reimbursements they provide, for example, to hospitals and doctors, and other factors will influence the premium. So the actuarial value may be exactly the same for this coverage tier, but the premiums may differ. And another piece of the plan comparison is the essential health benefits. This is what we talked about in the first webinar, and this is a minimum set of benefits that all plans have to cover in addition to meeting these 4 coverage tiers. An exchange must also enroll individuals when they come to compare plans and choose one. A couple pieces that do that. There's entities called navigators, which will be groups or nonprofits or others who will be funded by the exchange to conduct outreach and help people enroll. And again, the exchange has to fund them. They get they are paid to perform this function. They can be brokers. They can be nonprofit, community-oriented groups. They could be chambers of commerce. They could be any group that will be key in reaching the uninsured in your state, helping them learn about their new options and getting them enrolled. The exchange must have multiple ways for people to enroll. They can do it in person, online, or by phone, and they have to have one simple application so that there isn't a different application for every insurance carrier or every different program that's offered in the exchange. Another key function is something that's called plan management. So this is really the certification of plans to participate in the exchange. They have to meet certain standards to be a qualified health plan, which means they're one of the plans that can offer coverage in the exchange and get federal subsidies for those who enroll in them. Plan management includes things like rate and benefit review, so looking to make sure that the rate is reasonable for the benefits offered and that they do in fact meet all the benefit requirements in the essential health benefits, that their provider networks are sufficient to provide people with the care they need. This is called network adequacy, that they meet marketing rules so that they are not misrepresenting what they're offering in the plan or marketing in a way that discourages sicker people from enrolling in their plans and encourages only the healthy. So, for example, they can't just sell their plans in, gyms located on the second floor of buildings without elevators. Might be an example. They have to meet certain quality improvement requirements, and then they have to be accredited, which is actually different from most of the insurance that's offered in states now. The states generally don't require that they be accredited by something like the National Commission on Quality Assurance. Plans offered in the exchange will have to meet this requirement, and the exchange governance must make sure that plans meet all these requirements. And then there's sort of a catch-all function, which is a discretion to act in the interests of consumers. So beyond these minimum requirements that all plans have to meet in order to be a qualified health plan offering exchange coverage, the exchange operators can also then apply additional requirements that they think are necessary to provide benefits that are in the interests of consumers. This might be further standardization of benefits. It might be requiring all plans to report on their quality measures on a key public health goal like lead poisoning reduction or something. But it's this catch-all responsibility for the exchange to go beyond the minimum requirements in the federal law. And then plan management also includes ongoing monitoring. So not just the upfront certification to say, yes, I checked all the boxes for you, go offer coverage, but to continue to monitor and make sure they're meeting the requirements and providing benefits to their enrollees. Next. More in the minimum standards category. A key piece of this is coordinating with Medicaid and CHIP. And you may have heard a reference to no wrong door standard. This simply means that if a consumer or patient, family, individual walks up to the exchange or goes online to the exchange and says, I need coverage, what do you have? It's up to the exchange to figure out, is that person eligible for Medicaid? Are they eligible for CHIP? Are they not eligible for those things, so they're going to be enrolled in a qualified health plan, but do they qualify for a subsidy? That's all supposed to sort of work behind that front door, that it gets figured out for that person, and they're not sort of pushed from one place to the other, that the exchange says, nope, you don't qualify for private coverage with a subsidy. Go over there and talk to Medicaid to see if you are eligible for that. It will all happen right there, no wrong door policy. They also have to do what's sometimes called financial management, and this means particularly protecting against adverse selection. Adverse selection occurs when a plan somehow, either through marketing or plan design or other factors, manages to enroll a disproportionately healthier share of the population than their competitors, that some of the competitors are stuck with more of the sicker individuals in the exchange. There are three different mechanisms, sometimes called the 3 Rs, but reinsurance, risk adjustment, and risk corridors. And without going too deep on this, basically all of these three things go to simply saying that if you are a lucky plan that manages either by design or by default to get more of the healthy people than your competitor, then you owe money in a pot, and from that pot we pay those plans that manage to get the sicker individuals. So it really tries to take away the incentive for plans bending over backwards to find only the healthy and avoid the sick, because if they do that, they're going to have to, they won't benefit financially from it. They'll have to pay some of the money into the fund to offset the cost of those who got the sicker individuals. And we can talk more about that if anyone who wants. But this is going to be a key piece where exchange pilots or attempts have failed before in various states. It's because of this problem, adverse selection, that they ended up being the place where all the sick individuals went, and they couldn't survive as exchanges anymore. But I will say that even with these 3 Rs, if it's well done, it may not be sufficient protection, and states should consider doing more if they, with some of the options we can talk about later. So beyond these minimum standards, there are some key choices that states can make in designing their exchange. And I categorize this first set of choices as the weather options, whether to operate a state exchange at all or defer to the federal government to do it, or something now that's in between that's being referred to as a partnership exchange, partnership with the federal government, where the state does some of the functions and the federal government does some of the functions. They must decide whether to operate separate exchanges for individuals and businesses, which are known as the shop exchange, or to combine them, and whether to operate a statewide exchange, multiple exchanges within the state, for example, a downstate versus an upstate exchange, or to do a regional exchange with other states. This one has turned out to be more of a theoretical option, at least in the beginning. We know of no state that's now successfully trying to partner with another state, nor are they considering doing multiple exchanges within the state. One exchange within the state helps put together enough lives, enough bodies, enough enrollees that it makes it worth the time for the insurers to offer coverage. And it's become so politically loaded as in some of these decisions that figuring out how to make those decisions within a state is complicated enough without trying to line up your choices with one or more other states for a regional exchange. Now, the second set of choices I categorize as the how options, how to set up the governance of the exchange. The rule says it can be a public agency, either an existing or new one, a nonprofit entity that runs it, or a quasi-governmental entity. How to define the eligible businesses. The default is that the exchange will serve all employers with up to 100 employees, but states have the option of saying that at least initially they want to define eligible employers as only those with up to 50 employees. And in 2017, states can make the choice to allow businesses with more than 100 employees into their exchange. And then they also get to choose whether or not to operate a basic health plan. This is an option for states to come up with a different coverage option for people who are above the Medicaid eligibility threshold, up to 200% of poverty, which I show here what those incomes are, just so you get a sense of who we're talking about. And under this basic health plan option, the coverage must be must be as affordable and as comprehensive as the coverage the enrollees would have gotten if there was a qualified health plan offering their coverage instead of a basic health plan. And for reasons that we can talk about later if folks are interested, it can be financially better option for states because they get paid sort of a set amount of money for all those individuals instead of getting a federal subsidy for them. And if they can find a way to offer the coverage more affordably, they might come out ahead on that financial calculation. And it's probably going to be better coverage for those under 200% of poverty. But there are some arguments against doing it, too, that we can talk about if people are interested. There are a number of states that are at least looking at this, but no one's really jumped in with both feet to say they're going to do it yet, except possibly Washington, where this comes from. Washington has something called a basic health plan that they did on their own beginning like 15 years ago. Some other key choices that states can make, they can decide how to contract with plans. They can either do selective contracting, which is sometimes called active purchaser, or they can take a clearinghouse approach. Sometimes Utah is described as the clearinghouse approach. If you meet the criteria, you're in, and we're not going to apply any other criteria. And Massachusetts is sometimes referred to as an active purchaser or a selective contractor, so that they took some minimum standards that you might see here in the Affordable Care Act and required additional made additional requirements of the health plans. And there are many opportunities to use discretion. In Massachusetts, they did it to provide greater standardization. After they were operating for about a year, they did a bunch of surveys of those who had coverage through the exchange, which they call the connector, and asked them what they liked and didn't like about their coverage. And most people wrote back and said that they still had problems comparing plans, even with it condensed down to 3 different plan types. So the connector board required health plans participating in the exchange in the next year to meet other requirements. For example, they set the copays for key services that people said were particularly important for them, for example, doctor visits. Plans can go beyond some of the web-based tools that the Affordable Care Act requires exchanges to offer and do more to really sort of help people find the higher quality plans or to promote them in different ways with how they're presented on the website. And they can impose greater quality standards. I gave an example before with a public health goal, but there might be other things too. They're great at the top 5 chronic diseases in the state or something like that. Next. So what I just described is all that we have from the final rule that was published and taken this federally facilitated exchange, sometimes also called the partnership model, states don't really know what it would look like for the federal government to run the exchange for them or to do it in partnership with the federal government, with the state maintaining some of the key functions. Federal officials previewed for some state officials last fall how they might do that, and they said that states can either do plan management, and this is that function where I said they have to certify plans as meeting certain requirements like network adequacy and marketing. They could do select consumer assistance functions, or they could do both. But in all cases, based on what they previewed last year in a presentation to state officials, in all cases the federal government would do eligibility and enrollment and then share back information with the relevant state agencies like Medicaid and CHIP. But we really don't have a lot of information on this, and this is an area where states are really, I know there has been a letter from some governors to Health and Human Services saying we really need this information because as we think about how we want to proceed, we need to know what it would look like if we partnered with you or if we just turned it over to you. It sort of affects how we make some decisions about whether or not we want to do a state-based exchange. So where are states now? And I will say, as I begin this discussion, I've got some notes of my own that I'll go through with some discussion about what we've heard from various reports, but I also want to credit Marla for the great work that she's done on one of the handouts you have, which is the Excel chart that really captures in one place where states are, if they've enacted legislation, if they've, any official action they've taken, the funding they've gotten, and so forth. And we know from her chart and some sources she uses for that none now are partnering with another state to do a multi-state exchange. 2 states have said they will not operate their own, Louisiana and Arkansas. And I will say Arkansas has said that, Louisiana has basically said, feds come in and do it, we want no part of this, and Arkansas has said officially they'd like to look at the partnership model, how will that work. 15 states have established an exchange. 3 states have plans to establish an exchange. 19 are studying their options. And then there's this chunk of states that have taken no significant action. And to provide a little more detail on the next slide, here are the states that have established. And I will say that most of them have done it through legislation. And again, I should say that how states are getting to where they are now and how they will get to where they need to be for these exchanges to open doors on January 2014 will take a number of different paths. So in this case, the states that have established exchanges, most have done it through legislation. Rhode Island did it with an executive order, and most recently New York did it with an executive order when the legislature failed to enact the legislation that Governor Cuomo had introduced. When that failed, he issued an executive order to move things forward in New York. In Rhode Island, I don't know when they did actually, but it was a while ago, and so you may recall from an earlier slide, they were the only state to move to that final level of funding, the level 2 establishment grants, with the progress that they've made towards their exchange. For those that have plans to establish, Illinois and Virginia have done it via legislation, and Mississippi has done it through their executive branch. Many more are studying their options, many through executive order, fewer through legislation. And as I said before, Arkansas has now officially said they want to do the partnership model. Now, I'm going to go through sort of what we know, because that's sort of those categories of established and planning to and studying really sort of mask much greater variety in where states are right now. So I'm going to go through some notes we have from various reports. Mississippi and New Mexico are 2 states where there are conservative lawmakers, but they have made progress towards an exchange. Mississippi has a high-risk pool that their board has voted that they want to be exchanged. Now, it's a question about whether or not it would be an exchange that would meet the requirements of the Affordable Care Act and therefore get subsidies for their enrollees, but they're at least trying to move forward with embracing the idea of doing an exchange that's just not quite there yet with how they would do that. In New Mexico, again, it's a conservative governor who care. But there was a report that she sees it as a practical way to put Arizona's imprint on part of the health law that, if upheld, will have far-ranging impact on consumers, businesses, and the economy, read a recent report in the paper. So even while they may recognize, even while some conservative governors may say, we don't like the Affordable Care Act, we don't like Obama, they do recognize that if this is going to go forward, they want it to look like what their state needs and not some federal definition of what their residents need. The story of the last couple months has been a little more mixed. You might have heard that New Jersey, the governor just last week vetoed a bill and specifically cited the law's uncertain future as we await the Supreme Court decision next month. Illinois, there has been no bill yet, but the governor is apparently considering an executive order. Alabama, the bill passed the Assembly but was killed in the Senate. In Kansas, their governor, Brownback, is kind of infamous for trying to dispel any notion that he has any interest in the Affordable Care Act. Kansas, I think, got the biggest grant under the Innovator grants that I talked about on an earlier slide, and he very publicly returned the money and said, we have no use for these federal funds. And yet, their commissioner of insurance, Sandy Prager, a moderate Republican, has been trying to do some planning with stakeholder groups in that state, and now has said, though, that she can't imagine they will have time to do their own state exchange, and that's a lost opportunity, given how long the legislature and the governor have sort of dug in their heels and said they won't do anything. Kentucky and Nebraska, Michigan and Pennsylvania are all states that aren't officially working on a state exchange, but the staff is sort of unofficially working on it to move forward. I have a quote here from the Michigan governor. I do not support a one-size-fits-all federal approach to health reform, which is where we would be if we were to allow the federal government to run a health insurance exchange in Michigan, said the governor. But even if a health insurance exchange were not mandated by the ACA, I would still be in favor. And here is sort of the rub for some of these guys. This is a very Republican idea, this notion of a market-driven approach to private health insurance. So Michigan is a governor who is, trying to proceed even though his legislature has denied him a bill to establish one. Virginia is in a similar place where they've said that doing nothing is counterproductive. Louisiana is going to be a federal exchange for sure. And I just want to share one other quote from a person at Levitt Partners. Levitt was a former commissioner of insurance in Utah and the head of the Health and Human Services Department under a Republican president, I guess it was Bush. And he said, if the ACA didn't include exchanges as a method to distribute the subsidies, I guarantee there would be more exchanges up and running than there are today by a factor of 3 or 4 or even 5. So this really is, and I guess this is a little bit to arm you in the fight ahead, this is a very moderate approach to healthcare reform, to provide subsidies to buy private health insurance for those who need help paying for the premiums. Okay, we can talk now about the next slide. So what should you keep in mind with all of this information? Sorry, with this big dump of the federal rules and what's to come and the status of things in the states. The feds really are bending over backwards to give states as much room, as much flexibility as they possibly can to set up their own, enough room to set up their own state-based exchanges. That flexibility for advocates is both an opportunity and a challenge. On one hand, creating a state-based exchange means it's more likely to better serve the residents of the state than a federal exchange could. But it also means that your state has many more decisions to make and many more places that you want to pop in to be part of that conversation. It also means that in some cases some of the firmer requirements and timelines from the feds might have helped advocates in the state have some leverage with their state policymakers, with their legislature and their governor to say, if we don't do X, Y, and Z, then we get a federal exchange. Or if we don't act by this date certain, we get a federal exchange. And it's much more fluid than that. So it sort of disarms advocates in some ways that they don't have those strong-arm tactics that might be helpful in some states. A federal exchange isn't necessarily a better option, especially I think last year when some advocates were just starting to try to push some exchange legislation in their states, and some of the bills looked pretty awful. Health insurers are sort of running the whole thing, and it was hard to imagine how they'd make any decision that disadvantaged them. And so in many cases, some of those advocates, consumer advocates, said, I'd rather just see what the federal government will do. It's got to be better than anything we could come up with on our own. But I will just warn you that it's actually quite complicated to try to run this marketplace within a broader state marketplace. If the coordination and cooperation that's needed between those running the exchange and all the different state agencies that might come into play is going to be difficult even in the best of circumstances, even in those states where they say, we really want to make this exchange available to our residents, we just can't get there on our own, we want to partner with the feds. It's going to be complicated. Now imagine what that looks like in a state like Florida or Louisiana or Wisconsin, where they do not like the Affordable Care Act at all, and they can actually use some of their leverage in the outside market to disadvantage the exchange so that it will be set up to fail. So you cannot assume a federal exchange is going to be a better option. Some of the functions that states need to perform for the exchanges will be entirely new. Some of them are things they currently do to regulate to their private insurance market, the rules that they apply to insurers right now to sell products, to sell health plans in their state, but many of the requirements are wholly new and but completely necessary given the new responsibilities. And by this I mean, you know, what we're talking about here is not just licensing an insurance product to sell on the market, but to make it available in these exchanges with massive federal subsidies to help pay for people to enroll in them. That requires a whole different level of scrutiny and oversight. So it's appropriate that there are some standards that go beyond what states currently apply now just to sell a product in a state. We're talking about a whole different animal here. You want to know that for the expenditure of your federal tax dollars, that it's actually going to buy coverage that will work for people and isn't just money down the drain. And the political challenges that have made this difficult to date will continue. You all know, of course, about the Supreme Court decision that's due at the end of June. But there's some concern that even when that's resolved, if the law is upheld and technically, legally, states are free to move forward, we still have the fall elections to get through, and some states will still sort of pin their hopes on everything changing in the White House and Congress and everything else, that they won't have to comply with this if they just wait a little bit longer. If it is upheld and we still have a President Obama, states are going to have to scramble pretty fast to start to line things up if they want to still do a state-based exchange. And some of that you could hear in the quotes I was reading about those governors who said, we are not well served by waiting this out. So for the next slide, what can you do now, given all this? I will say if your state has a process, and Marla's chart will help you figure that out, track it and find out where your opportunities are to engage. Some of them are officially holding public meetings that allow for public input. Others are open meetings where they meet, don't necessarily allow for public input, but it's all there for you to see, and there are other ways to weigh in. If your state hasn't made progress, we would recommend that you get to know your insurance commissioner now, and this is really about my warning that if this is upheld and this all is going forward, we know that there are some states that have officially said we're not doing anything until this is decided, but they have quietly started to at least think about this because they recognize that if it's upheld, they don't have enough time to quickly put this all together, and they may have some very angry residents on their hand who say, well, now that you've waited this out and delayed, now we're going to get that federal exchange, and we would have rather you took responsibility for doing something for us. So my recommendation is, if you haven't already talked to your insurance department, you should do so, and not wait until the decision comes down from the Supreme Court and everyone's lining up at that door to sort of get their say about how an exchange should be developed in your state. This will be key. They'll have, even if it's not a state agency that's running the exchange, the insurance department is going to have some key responsibilities and a key role in the exchange in your state, and it's worth getting to know them and starting to share with them your concerns as patient advocates, so they start to incorporate that in their thinking and their planning. I would also recommend you pick your battles and prioritize your goals. even in the best-meaning states. California passed legislation in 2010 to establish an exchange, and even California is starting to figure out that it's going to be hard to get all these boxes checked before January 1st, 2014. Even with everyone trying to move forward together, there is a lot to do to get these things up and running and open on day one. So you should pick your battle. So for example, some of the quality requirements have been officially sort of punted down the road. This is not, this is not going to be all the bells and whistles in place on day one. You're going to have to figure out which things you want to evolve over time and come on in later years, and figure out what you need on day one. And then I would also recommend that you keep your options open and don't tie the hands of the exchange. So this goes back to that notion that the exchange has certain requirements they have to meet in certifying plans, but then there's that catch-all responsibility to act in the interests of consumers. There have been some political battles in some states where this active purchaser name has gotten such a bad rap that some legislation has said the exchange cannot be an active purchaser, and that's a lost opportunity. I think it's better to have the legislation or the executive order, whatever it is, be silent rather than shut down that possibility, because there's some things that they can do with their contracting with plans that better serve consumers, and you want to at least leave that door open to doing that later. Maryland, for example, has said that their exchange should consider it in the early years, but they don't need to do this sort of selective contracting, but they are leaning towards in some, the third year out that the exchange has to start selectively contracting and not just accepting plans that meet minimum requirements. So that is, I want to end here, with resources you can use. So there are two great places. In addition to Marla's chart, she borrowed from these two sources, and these are great ways to stay on top of whatever is happening. For the status of exchanges in each state, there's a part of the Kaiser Family Foundation website called statehealthfacts.org that really allows you to pull down what kind of funding they've gotten, if they've moved forward with a legislation or an executive order, what kind of governing board they have, and so forth. And then the second resource here is also a Kaiser Family Foundation resource where you can actually, from a drop-down menu, enter your particular state and then get the full picture, including next steps that they're going to undertake, and if there's a website for the exchange or sort of some way to contact the official decision makers and jump into the process. So happy to take questions.
I just wanted to, we're going to take a look at who all has questions, and I will unmute your phone so that you can ask your question. First one I see is Natalie. I'm going to go ahead. Your phone is unmuted if you would like to ask your question. Natalie? Okay, she may not have heard me, so we'll go on to Ruth Lynn.
What?
Ruth Lynn, you had a question?
No. Go ahead.
Okay. Not seeing other hands raised. Does anyone else have a question? If so, hit your, oh, here we go. Terry, I've just unmuted your phone.
Okay, you can hear me, I guess?
Yeah.
Mm-hmm.
Yeah, okay, so my question was, obviously we're all representing ourselves blood plasma users, expensive treatments. How does that play out with the required benefits and the maximum copays and deductibles for a year?
Well, I don't know if you were on the first webinar, but there's a couple pieces from the Affordable Care Act that will come into play. One of them is essential health benefits, which we talked about last time, and I know that Marlene said in the beginning that that's available on hopefully on your organization's website. But the essential health benefits is that minimum set of services and benefits that all new plans in the small group and individual market have to offer beginning in 2014, and it defines out, according to 10 general buckets of coverage, what plans must cover. That applies to plans whether they're offered outside the exchange or inside the exchange. And that is definitely a piece of this that will affect directly the kind of care that you have. If a benefit or service makes that list as part of the essential health benefits package, then the law says that there can be no lifetime or annual limits on those benefits, and it caps the out-of-pocket expenses that individuals will pay for those services. That means that if a benefit or service is not on the list, there are no financial protections like that. So that's a key piece. Within the exchange, network adequacy is going to be a really important piece of this. Some states have network adequacy requirements for HMOs in their state, but not for other, like PPOs or some other plans. But every plan in the exchange has to meet network adequacy requirements, and how that gets defined to make sure you have access to all the specialists and treatment sites that you need will be a key piece of it. How the plans define medical necessity so that you can get the services you need. I would say that marketing is an important piece for patients with expensive health conditions too, but the network adequacy piece, whether or not the state's going to have a standard for prior authorization for services for plans in the exchange, will also be important. But one of the things to keep in mind, because this is an exchange within a broader market, while the temptation may be to make it really robust inside the exchange, great benefits, beyond what the essential health benefits may offer, really wide open networks that allow everyone to see everyone they want to see without out-of-network charges. You don't want a big difference between the rules that apply to plans inside the exchange compared to the rules that apply to plans outside the exchange, because that sets up a situation with the adverse selection that I talked about earlier, where the only people that go into the exchange are the ones who have costly health care conditions, and that's a recipe for premiums just going up and up every year until it's completely unsustainable. Does that help answer some of the?
It does. It certainly makes me nervous as a plasma user.
Well, and this is the thing. I think you could talk about this stuff in the abstract, and there are these network adequacy requirements that are applied to some plans. But this is the point. I know you have enough going on in your lives, but the point is to get involved where you can. And even if you don't have the answers for how this stuff gets done, I think telling your story about what care means to you and the hurdles you already go through, and to make sure that they keep real patients, real people in mind as they make these decisions. And it really is, I think you can, on the basic level, advocate that this is a whole different ball of wax. This is not just licensing insurers or approving insurers to offer some plans out there for people to buy. This is a whole different level of scrutiny to qualify for subsidies.
One thing I'd like to add to that, this is Michelle Rice from NHF, Terry, is that the A+ group did submit comments on regarding our concerns about essential health benefits. You can find those, I know they're on our website at hemophilia.org, but we did submit comments about concerns about access to all specialists, access to all therapies, and network adequacy. So I know that we've not only submitted comments in writing, we actually went and presented our comments at a listening session that HHS had sponsored as well. So we are definitely all, and then our individual groups have also responded as well. So we are certainly trying to make our voices heard on the federal level, and we've encouraged our local advocates to do the same on the local level.
Well, and because you shared this with me, Michelle, the other piece of the network adequacy rule that I failed to mention, and I know your comment letter addressed, is they must include something called essential community providers. There's broad discretion given to the states to set their network adequacy standards, but there are some minimums they have to cover, and one of those is to make sure that every plan includes essential community providers to be defined, and those could and should include HTCs.
Okay, let's move on. Let's see if Natalie, Ruth Lynn, did you have a question, or? change your mind, or? Ruthlin, no?
Sorry.
Okay.
No. My
Okay.
phone keeps
Okay.
messing up.
Okay. Natalie, did you have a question? No? Anyone else with a question for JoAnn? I will say that if you don't, if after we get off the phone you realize that you have a question or there's something else you'd like to ask, you can email either Marla Feinstein or myself, and it's I believe that our email will be on the our email address is on the follow-up email you will receive after this webinar is over. And if anyone on the call did not receive the slide, or did not receive the handouts that were emailed out yesterday, again, please also shoot us an email or pop a note here into chat so that we can get those sent out to you.
Yeah, and it is a lot to digest, both the slides and the handouts, so more than happy to take some questions after the fact, after people have had a chance to really digest it all, if there's something that comes up.
Okay, well, I believe that since seeing no, oh, nope, I do see, I'm sorry. Elizabeth Stoltz, you had some questions?
Yeah, quick question. So as patients who are using plasma-based therapies look at the variety of plans available on the exchanges, and they'll see that a platinum plan has a higher premium, a bronze plan has a lower premium, but they all have the same out-of-pocket cost. Is it better for them to choose a bronze plan, or is that not, I'm not trying to game the system, but I'm trying to figure out if that just makes more sense.
Right, and that's the whole point, is not to game the system, but the idea is that you should be able to make an informed decision. And actually, what will differ between those 4 levels of coverage is not, it's going to differ not in the benefits, but in the, well, I should maybe caveat that, but the difference should largely be around your out-of-pocket costs. So remember that the platinum plan, on average, will cover 90% of the costs for an average patient. And so that means lower deductibles, lower copays, but likely a higher premium for that plan. And the bronze at 60% value will cover less of the services and have more cost sharing, more higher deductibles and copays for individuals. All of them are going to have the out-of-pocket max, but it will depend also on where they, well, I think here's some things to look at. So a plan with the same actuarial value will have the same overall costs that you would have to pay out of pocket potentially, but it's worth looking at where they actually apply the out-of-pocket costs. So a plan might choose to put a lot of it in the deductible, like a big deductible and low copays once you've met the deductible, or it could do a smaller deductible and bigger copays. I think it's worth probing around to see where the copays actually fall, even where their plans are the same tier, to see which one better serves you. But they should all offer roughly the same benefits under the Essential Health Benefits Package. One thing we don't know yet about those benefits, I will say, is we don't have a final rule from the federal government. If you heard the webinar last time, we have what they're proposing may be the approach, and we're waiting for the actual final word on how this will happen. But one of the things they're considering is giving insurers flexibility to interpret those 10 categories of coverage. So if that flexibility is allowed, that's another thing that you're going to want to look at, exactly how they define those benefits. But that piece should be more similar across all plans, and the difference should be in the cost sharing. And so that should simplify your choice. I hope that was helpful.
Also, Elizabeth, this is where patients can utilize the insurance toolkit that we have to help them kind of identify where, make those decisions and compare the costs between those plans to decide, which plan they want to choose. And did you
someone's immunologist, a patient with primary immune deficiency, if their immunologist happens to be out of network in the plan they choose on an exchange, there will be I would assume there would be a higher copay to go see that immunologist. Does the out of network, I mean, is there going to be a cap on? I'm not phrasing this right. Will an out of network, out of pocket cost still apply towards that out of pocket limit, or if you go out of network, does that not apply to your out of pocket cost? Do we know that yet?
Yeah, I need to double check this. Yes, it should apply. Well, actually, I don't know, but I'm sorry, I need to check that, and that's an answer that I should follow up on. It's an important one. And the other thing I know that they can do balance billing, and your state can do legislation to prohibit the balance billing. So even if it counts towards the max, if you go out of network and pay higher copays for the service, does that count towards your out-of-pocket costs is one of the questions. And I don't believe it does, but I have to double check that. But the other thing that could really be a problem is if the state allows balance billing. And that means that the health plan has a certain amount that they reimburse the provider for a service, but if the state allows the providers, if they charge $200 for a service, just to make things simple, and the health plan reimburses the $120, they can cover you for the $80 difference. And those can start to really add up for costly procedures. So that's an important state protection that can be enacted, is to prohibit the balance billing. And I need to answer your first question definitively. We can shoot you a note, but also make it part of the
in whole controversy. Health plan, health insurance plan should be able to protect. And I was wondering what the conventional wisdom is for that. You can make a pretty good case both ways, but I'm not sure which way to go.
Well, what the rule says on this is that, for some reason, echoing, but this is one of the open questions from the proposed rule.
Ooh, I don't know why that's
here. Is it Phil? Maybe you can put us on mute or something. Maybe
Excuse me?
maybe can you put us on mute as I mean mute your phone while I give the answer, because it sounds like it's bouncing. This was an open question that was posed in the proposed rule last year and answered in the final rule. And the final rule says that for the governing boards, which is what I think you're talking about, and you're right, it's been very controversial. It's gotten some press coverage. For the governing boards of who makes decisions in these exchanges, the final rule says that at least one of the members of the board must be a consumer representative, and the minimum standard is that a simple majority of the voting members cannot have a conflict of interest, which is what folks generally believe insurance companies have, is that they can't make decisions to affect the operation of an exchange that they wouldn't benefit from. But all that the rule says is you can't have a simple majority that would have a conflict of interest. It necessarily means that you can have a conflict of interest and serve on the board. It just can't comprise a simple majority. And I think that's in part because some states that did move forward set up exchange boards with insurers' representatives on it, and the federal rule is not going to make any state backpedal from where they'd already gone. If that answered it, great. If not, unmute and probe some more. I think I got what you were asking, though. Okay.
unmuted.
That was perfect. Thank you very much.
Okay. Okay. Thanks for the question. Anyone else?
plans. For example, I don't know what the current thing is, but when I checked a year or two ago, the Utah exchange did not apply to somebody who was self-employed with no employees. In other words, you had to have at least 2 people on the plan. And is that something that states can still do, or will be able to do in 2014?
I think this is still an open question, and it's in part an open question because states do define their small group market, that is the place where small businesses buy coverage, differently. And some will say 1 to 50, meaning you capture everyone from the self-employed to bigger companies, and some will say 2 to 50. And it goes more to the definition of how they define their small employers for the small group market in the state. And I think this is actually an open question in there's a group called the National Association of Insurance Commissioners. I think it's going to track the state definition, and the important thing is whatever the definition is, if it does include self-employed, if it says a small business is anyone from 1 to 50, that self-employed person should not be able to choose if they want to treat themselves as an individual and go shopping in the individual exchange, or as a small business of 1 and go shopping in the shop exchange, because that could create some selection problems. Giving them more choices, whether for the individual or the plans, can create opportunities for that selection. So I think it's going to be defined by however they have it currently in their state law, unless they change it.
Okay, did that answer your question, Mary?
Yeah.
Okay.
Thank you.
Mm-hmm. Next question is Glenn. Glenn? Maybe we lost him. I'm trying to see if anyone else had another question. And I think that is it. What we will try to do. Oh, there he is. There he is.
Yeah, I'm back. I'm sorry.
Okay.
It's Glenn.
Yes, go ahead, Glenn.
Hi, it's Glenn Monis, New York City chapter. I'm trying to get a sense. I realize that the law was structured in such a way as to prevent the occurrence of significant disparities between the states, but it seems like that's still likely to occur to a degree. So what do we anticipate will be the degree to which we're going to have good and bad states in which to obtain insurance?
Good and bad. Well, what's sort of interesting is, I guess I would define bad as a bad exchange as one that doesn't really, that is more of a clearinghouse and just applies minimum standards and allows a lot of flexibility to the insurers. However, that might also be the exchange that's not attractive to people to enroll, and so then that state will not get as much of the federal subsidies as another state who puts together a great exchange that attracts a lot of enrollment would get. So in some respects, it's sort of this interesting flip side that if they do a bad exchange that's not particularly successful, they also are going to lose out on a bunch of federal money, because like the planning money for states, the exchange subsidies are also sort of a open checkbook. There's no capped amount that, if you're the last state in through the door, you hit the limit and your folks don't get a subsidy. Everyone gets the subsidies they need. So I think that that's sort of where I would say the differences will occur. If it's an unsuccessful exchange with little enrollment, that means their residents are losing out on federal subsidies that would help them buy coverage. There is a question about whether or not these exchanges are going to be attractive to anyone who doesn't qualify for a subsidy. They sort of have this captive audience that if you want financial help to buy health insurance, this is the place to go. But the bigger question in establishing these things is, if you are over the 400% of poverty and would have to buy it without any subsidy, is it also still attractive to you? And importantly, that's a big question for small businesses, because while the small business tax credit for small low-wage firms is only available in the exchanges beginning in 2014, it is candidly not a lot of money, and it's targeted and temporary. I think it's 2 or 3 years maximum that you can get it, and then you no longer can get the subsidy. So I know that states are really struggling, exchange planners are really struggling with how to make them attractive, particularly for small businesses, because it's hard. There's less of what they're offering is not dramatically different from what the outside market can offer other than this small targeted subsidy for certain firms. And so they're struggling with how they show that they're doing something different that warrants small businesses going there instead of continuing with whatever they do now with their broker and buying outside the exchange.
Thank you.
Great. I just have 2 more to check. Phil, did you have another question, or are you good?
I'm good. Thank you very much.
Okay.
And this has been very informative. And fortunately, without the tech problems in the first one, it was great. Thanks. As we say in Hawaii, mahalo. Nice job.
You have no idea how excited we are. And Elizabeth, did we get all of your questions? I think we got all of them. Okay. Okay. Well, fantastic. Again, we will get the recorded copy of the webinar out to all of the different patient groups, and so hopefully they can get it up on their website so that you can see that, and they hopefully will also have up the documents that were passed out tonight. If not, you can come to hemophilia.org. We should have those up on our website by Friday. And we will also try to post at that time a list of some of the questions that were asked in the question box and the answers that were given. And if you have any additional questions, please go ahead and email those to Marla or I as well. And thank you to JoAnn, and we look forward to our next webinar. So watch your emails, and thank you, everyone, and have a good evening.
Thank you.
Mm-hmm.